Hi everyone, we'll start with chapter 27, Hematologic and Lymphatic System Function Assessment and Therapeutic Measures. And again, as always, I'm going to flip through the objectives, just make sure you're looking at those at the beginning of the chapter. Anatomy and Physiology Review. So when we talk about this chapter, it's important that you revisit what you learned in anatomy and physiology related to the hematologic system on the left-hand side and the lymphatic system on the right-hand side. So when we're talking about this section, you need to think back to bone marrow, blood, and blood components. And those are all part of the hematologic system, okay? Blood components are things like plasma, red blood cells, white blood cells, and platelets. So those are components of the blood that we're going to look at specifically and how those change with different disease processes. On the right-hand side, the lymphatic system, so this includes lymph nodules and nodes and also lymph vessels. So lymph nodes and nodules, these are really important for filtering out pathogens and destroying those pathogens. So we need a lymphatic system that's functioning properly to help prevent us from acquiring and developing diseases. Lymph vessels, which are illustrated in the graphic there, kind of shows the lymph vessel system throughout the body, and then those little green, larger circular type of things, those are the nodes and nodules. The lymph vessels return lymph to the blood, so that's an important process as well. Blood is really important for regulating body temperature. In your book, figure 27.1 is also helpful to look at to identify the different components of blood. So blood regulates body temperature. You'll notice if somebody's anemic or they have a low hemoglobin or those types of things, they tend to get really cold. And that's because they don't have adequate blood supply in their body as far as it's not balanced. So we tend to see people that have abnormalities in their blood, whether they don't have enough or the components aren't right, they tend to get pretty cold. Maintains pH and fluid balance, transports cells that protect the body. On the bottom there, you'll notice blood, when it's collected from our patients, it's put into a small collection cylinder device, and then when that's spun down in the lab, we can spin blood down and it'll separate, you'll see on the right hand side, into red blood cells, which are on the bottom, white blood cells and platelets, which are in the middle, and plasma, which is on the top, and that has to do with the weight and specific gravity of everything when that's spun out. If we're going to collect things from blood, such as plasma, that's blood has to be spun down so just the plasma can be collected, for example. Normal blood pH is 3.75 to 7.35 to 7.45. 7.35 to 7.45. Plasma is very important. It's a transporting medium in our body. Proteins are synthesized by the liver, and these proteins, prothrombin and fibrinogen, are really important clotting factors, and those are within plasma. So if we don't have adequate plasma, we are at risk for not being able to clot. Plasma also contains albumins. They help maintain our blood volume, and globulins, which are carrier molecules. Plasma, which is a component of blood, very important for maintaining body temperature. Plasma is about 91% water. The globulins, these carrier molecules that I mentioned, they carry things such as fats, antibodies, those types of things. Plasma gets warmed up by passing through active organs such as the liver, skeletal muscles, and then it distributes that heat throughout the body. So when we talk about, blood regulating body temperature. It's really the plasma within that blood that specifically does this, okay? And that plasma, as it passes through active organs in our body, it gains that heat, or it passes through skeletal muscles that are active. It gains the heat that it needs, and it redistributes that heat throughout the body to keep the body temperature regulated. Red blood cells have a 120-day life cycle. So you haven't talked about diabetes yet, but this plays a key role in why there's a lab value called a hemoglobin A1C, for those of you that may be familiar with that. And that's a lab draw that can be taken off a patient to see what their hemoglobin levels related to their blood sugar have averaged. It's a test that's really helpful because a diabetic patient can't cheat that test. And what that test is measuring is that red blood cell life and the sugar content and such. So that's just kind of helpful to think about. But red blood cells, they replenish themselves. They only last about 120 days. They carry oxygen bonded to iron in hemoglobin. So red blood cells are really important when we're looking at the values for our patients. If they have low red blood cells, then we are concerned that they also potentially have low iron and low hemoglobin. And we know that we need hemoglobin as an oxygen carrying component, so we worry about oxygenation throughout the body when hemoglobin levels are low. So there's reduced oxygen carrying capacity that can cause anemia if red blood cell levels are low. And some of the signs and symptoms we might see is shortness of breath and fatigue in these individuals. So think back to nursing concept clinicals. Did you have anybody that was anemic or chronically anemic? Or did you have a patient that took iron supplements, folic acid? Why were you giving that to the patient? Think of those types of things. Hypoxia stimulates kidneys to secrete erythropoietin, and this causes an increase in red blood cell production and increased oxygen carrying capacity. So in reading that, what is so neat is that our body is amazing. And when we are hypoxic or we are low on the oxygenation and perfusion within our body, our kidneys go, hey, I think the body needs a little bit of help. It secretes erythropoietin, and that causes red blood cells to be produced faster, okay? So there's more red blood cells to help kind of balance out the things that are happening that shouldn't be happening. A good example of this is if you think about, have you ever heard of athletes that will go train up in high altitude? So they'll go train up in the mountains because the air is more hypoxic. And as a result of that, their body will release that erythropoietin and make more red blood cells. And then when they come back down to sea level to compete in their events, then they have more red blood cells than they would need living at sea level. So they have more oxygen carrying capacity within their body that's going to help them perform better. So really interesting stuff. But I think sometimes when you can relate it to real life, it makes it more easy to understand. All right, good. Blood types are very important to our nursing role because as LPNs, you're not administering blood. You'll do that as registered nurses, but you could very easily be taking care of someone who is receiving blood, and the RN is monitoring the blood transfusion portion, but you're taking care of the patient. So you have to be as knowledgeable about this as you would as a registered nurse. Okay, so our main blood types, A, B, and O, and then antigens on the red blood cell. So the blood type stands for the antigen. And then knowing that if you have type A blood, you can donate to A or AB. B can donate to B or AB. AB can only donate to AB. And O can donate to everybody. A, B, AB, and O. And that's why O blood is so sought after, because it's a universal donor. And then when we talk about universal recipients, so if somebody is AB positive, they can receive blood from anybody. So O can donate to anybody, AB positive can receive from anybody. The spleen is located in the upper left quadrant, kind of behind the stomach that you're going to notice on this illustration. It's protected by the rib cage. The spleen is not a vital organ, but if it is removed, individuals can be more prone to bacterial infections such as pneumonia or meningitis if they have their spleen removed. As nurses, we hear about a lot of injuries where the spleen is involved, and we fear about bleeding and risk for bleeding because the spleen stores so much platelets. So a lot of times if kids or adults have injuries to their spleen, they aren't allowed to do contact sports or anything like that because you worry about their ability to clot if they would become injured. So the spleen contains B cells and T cells, which help with our immune response. And that's why when we don't have our spleen, we're more likely to get infections like meningitis and pneumonia. It warns of defective blood cells and platelets, and it also stores 1/3 of the body's platelets. So that helps with clotting. There's a video on Brightspace related to the spleen that I typically show in class. Formation of a blood clot. So really important to understand how a blood clot forms. Prothrombin activation, when prothrombin is present, when thrombin becomes present, when that fibrin becomes present. So it's kind of a building cascade on itself. And it has to do with an intrinsic and an extrinsic pathway. And due to the size of this slide, which comes out of your textbook, I really want you to look at this better in a larger view. Page may be different because we updated versions, but figure 27.4. When you think of platelets, platelets are what we need to clot. So if we don't have platelets, we risk our blood being able to clot and being able to stop a bleed. So somebody that you're taking care of that has low platelet counts, they are very high risk to bleed and not be able to stop that bleeding. Okay, platelets are very sticky and they stick together to form that clot. So I want you to take a little bit of time to look at this illustration and how these platelets stick together, how the prothrombin and thrombin are activated, and then the fibrin mesh that kind of creates a stable hold to make the injured cells clot and stop bleeding. Health history. So when we are assessing our patients related to hematologic and lymphatic systems, we need to collect subjective data. So remember, subjective data is what the patient says. So table 27.3 is where you're going to look for this. And the reason, or what we're trying to collect from our patients, is why are they seeking care? What's their family history? What's their diet history? What medications do they take? Have they had any occupational exposures? Any fatigue? Any bleeding tendencies? Any respiratory symptoms or illness? Any skin changes? And any lymphadenopathy or any swelling or abnormalities in their lymph system. So let's kind of break this down just a little bit. We'll talk about this some more in the slides to come, but when somebody comes in and they are hematologically imbalanced, we worry about what meds they're taking, because if they have, for example, low platelets and they're at risk to bleed and they're taking things like aspirin, ibuprofen, things that are going to make them increased chance to bleed, that's a huge concern to us. If they have occupational exposures, let's say they have low platelets, increased risk for bleeding, and they're doing work that puts them at high risk for injury. That's a great concern to us as nurses. If they have fatigue, when we think back to the previous slides, or any respiratory symptoms like shortness of breath, we're going to be concerned. Are they anemic? Did they have a low hemoglobin values? Those types of things. Any skin changes. So somebody that's at high risk to bleed, we definitely have to inspect their skin and notice if they have any bleeding or bruising. Somebody that has low platelet counts is going to be really high risk for bleeding and bruising. Looking at the graphic here, the aging hematologic and lymphatic system. So as we get older, we have less efficient immune response, increased risk, which increases our risk for infection. We have natural iron deficiency, which is why all older adults take an iron supplement, okay? And that increases our risk for anemia. We also have slowed erythrocyte production. Remember those erythrocytes produced from the kidneys, which help us create more red blood cells. And as we get older, that's reduced, which increases our risk for anemia. And we have reduced plasma volume. And so plasma is primarily water, and that increases our risk for dehydration. So just all things to think about as we're taking care of our older adult population. When we're doing health history, we're always looking for abnormal things. One of those abnormal things that you're going to see for somebody that has hematologic disorders, such as abnormal bleeding anywhere in the body, is something called petechiae. And these petechiae look like tiny pinpoint little red dots, okay? Small purplish spots under the skin, but they're very significant. And if you would ever notice petechiae on someone, usually they appear pretty quickly and they really indicate to you that something is wrong, okay? Something is wrong. This is not like little redness you get with dry skin. These look different. So when you see them clinically, you'll definitely be able to tell that's not dry skin or, skin that's damaged in the winter. This is different. And if you see that, you always want to report that to nurses you're with and your providers right away, because something's happening, okay? As far as hematologic unstable, these can happen anywhere on the body. On this person, it's on their neck, but these could be on the chest, on the back, all over the body. Other things we're looking for: ecchymosis, large areas of discoloration from hemorrhage under the skin. So this is that purplish kind of abnormalities that we're going to see. You've probably seen these on older adults if you work long-term care, the little discolorations, the ecchymosis all over their arms, especially if they're taking blood thinners or those types of things. So they're little hemorrhaged areas right under the skin. And, it could be as simple as somebody bumps their arm on the table as they're scooting their chair up to eat supper, and it creates these discolorations. So, that can be a normal finding in someone that we would expect due to aging and due to Coumadin use and those types of things. This would definitely be an abnormal finding on a younger adult with no predispositions of abnormal clotting. Purpura is something else we're looking for: hemorrhage into the skin, mucous membranes, and organs. So if we look at these illustrations here, it's not really bruising, but it's also caused by hemorrhage, and we classify it as purpura, and it looks different. So when you're looking at these illustrations, think about how this looks different than a bruise, and this is classified as purpura. In our physical assessment, we're also looking always at vital signs. We're always looking at level of consciousness. Remember, someone that is fatigued or weak, confusion can all be signs of hypoxia. We're looking at the skin and the mucous membranes for bruising, purpura, petechiae, ecchymosis, all those types of things. We're looking at the fingernails. We're looking at the abdomen. We're looking at the abdomen for any signs of flank bleeding, and also, as you saw in the illustration, any bruising. Looking at the neck and axilla for any swollen lymph nodes, any abnormalities in skin color, and looking at the sternum. In your book, it does a good job talking about all these abnormalities in table 27.4. So all the abnormal things that you're going to see in your physical assessment related to hematologic or lymphatic issues. The pictures that are on your screen, there's a picture of spoon-shaped nails. So make sure, no matter who you're assessing, always look at their nails. They will tell you a huge story, not only about hygiene and those types of things, but also just about perfusion and things that are going on. So spoon-shaped nails, which is that top illustration, that is what nails will look like if someone has chronic anemia. And then the picture below it, clubbed nails. This is someone who's long-term hypoxic and can also be anemic as well. But we especially see these clubbed nails, this lower picture, in somebody that's a smoker for a long time, or has a chronic lung disease for an extended period of time that causes them to be hypoxic. Diagnostic tests. So blood tests, coagulation tests, bone marrow biopsies, lymphangiography, and lymph node biopsy. So I'm going to talk about these individually here. So blood tests that we're always looking at would be our CBC, so complete blood count, total hemoglobin concentration, which is our hemoglobin value, hematocrits or hematocrit value, and platelet levels. Normal values are all going to be on table 27.1, and I want you to have a general awareness of what normal levels are for things like red blood cells, white blood cells, hemoglobin, hematocrit. Some of it's broken down by male or female, but those are things you need to know, because when you get report, the nurse is going to tell you, and their red blood cell count was this, and their white blood cell count was this, and their hemoglobin was this. And if you don't know what normal is, you're not even going to know if your patient's impaired. So you have to be able to just have those values memorized and apply them to your patients. So really important to know those. Coagulation tests are also table 27.5. So if somebody is on Coumadin or warfarin, we need to know therapeutic INR. So INR is very important for somebody that's on Coumadin or warfarin. If they're on that medication, therapeutically, we want to keep them at 2.0 to 3.0 for their INR reading. If their INR drops below 2, their blood is getting thicker. If their INR goes above 3, their blood is getting thinner. So who's at greater risk to bleed? Somebody that has a high INR or a low INR? A high INR. Who's at greater risk to clot? Somebody with a low INR or a high INR? A low INR. So that Coumadin is adjusted, and that's why lab values have to be taken routinely to see what that INR level is, because we want to make sure, especially if somebody gets sick or something happens, that's when they could have, a stable Coumadin level for years, and then all of a sudden it fluctuates, their INR fluctuates. So really important in your nursing role. Bone marrow biopsies, obviously, those would be done, usually biopsies related to cancer types of situations, or collecting bone marrow for giving it to someone else. Lymphangiography is evaluating lymphoma or metastatic cancers. So with this, if you look at the word angiography, so this is always when dye is injected. So like if there's an angiogram of the heart or those types of things, but in this case, the dye is injected into the lymphatic system, into the lymphatic vessels. It's usually done in the hand or the feet. And then they use x-rays to determine lymph flow or blockages. So, with this, if anybody has any sort of angiography where dye has been injected through some part of the body, as nurses, we worry about that site bleeding after this is done. So really pressure dressings, monitoring these patients for bleeding, and also that with this type of angiography, the skin, urine, and feces can have like a blue tinge for a couple days after, as that dye works its way out of the lymphatic system, and that's a normal finding. So it's used for diagnostic purposes if the lymphatic system or metastatic cancers are potentially present. Lymph node biopsy, typically what we do in class, there's a critical thinking exercise on Mrs. Brown in this chapter that we talk about a little bit, and that's kind of helpful to give you a little bit further understanding. Blood products. Blood products is what we're going to finish out chapter 27 with. So we'll talk about things to be aware of with blood administration. Remembering that as LPNs, you're not administering the blood, but you're very much going to be responsible for a patient who may be receiving blood. So you're the second set of eyes and ears to be monitoring what the registered nurse has hung, and knowing reactions and what to look for, and proper procedure, all those different types of things. So blood products, we have packed red blood cells. We have frozen red blood cells, platelets, albumin, and fresh frozen plasma. Table 27.6 kind of talks you through these different blood products and why they are used. These are all going to be given through an IV. So your patient's going to receive these through an IV. All of your patients are going to be typed and cross-matched before they can receive these products, unless it would be an emergency. And if you think back, if it were an emergency, what type of blood could we give to anybody? What's the universal donating blood type? Okay, so I want you to think about that, a little bit as you're going back through your notes. But if we look here just at this fresh frozen plasma that's on your screen, so you'll notice in the upper right-hand corner, it's AB is the type. And so that's really important. We'll talk about on the next slide how we kind of identify everything. But just know that these are the different kinds of blood products that you will see given. Why would one be given versus another? So red blood cells are going to be given when somebody has low hemoglobin and hematocrit values, low red blood cell counts. Platelets are going to be given when platelet counts are low. And then as far as albumin, fresh frozen plasma, those types of things also associated with poor clotting factors and results of low albumin when the blood test is done, low plasma counts, those types of things. Blood administration. So blood can only be given with normal saline, so 0.9% sodium chloride. There is special blood tubing that is used, and it is Y tubing. So it has a big filter on it, and then it has two different ports. And usually in class, I draw this on the board, but there's one piece of the tubing that goes up to a bag of normal saline. There's one piece of tubing that goes up to your blood, and then there's a filter that those both come down to, and then a main line of IV tubing that goes to your patient. So you can only use normal saline as that second solution, and that's the only thing compatible with blood. Blood is transfused usually over 2 to 4 hours. If it's not at all infused within 4 hours, then you have to stop administering. And every hospital is different according to their policy. But why would you infuse it in 2 versus 4 hours? Some of it just depends on your client's overall health. So somebody that has a weak heart or cardiac issues or heart failure, we can't give them a bunch of extra fluid quickly through their veins, or it could put them into fluid overload. So in those patients, we give it a little bit slower than somebody that's a little bit younger and healthy. So there's blood tubing that has a filter. As nurses, we're going to take vital signs before we start the transfusion. And then as nurses, we will go down to the lab and receive the blood, go through all kinds of checks and balances to make sure we have the right patient, the right blood. We do that with the lab tech, and then we bring the blood back to the unit, and we have to start that blood infusion within 20 minutes typically. So with that, you need to make sure you have to have a second registered nurse, and these are registered nurse to registered nurse, but you still need to know the process that would verify that blood at the bedside as well. So make sure you have your person available when you get back with the blood, and you're not waiting for someone to start that blood administration, because you might lose that 20 minutes of time. A registered nurse has to stay with the patient for the first 15 minutes of the transfusion. That cannot be delegated to a CNA because the nurse is monitoring for transfusion reactions, and CNAs are not educated on what to look for, okay? So we also have to do routine vital sign monitoring. That's going to vary by facility, but usually we take vitals before we start. We take them 15 minutes in, and then we take them every hour while the blood's transfusing. That's kind of best practice, and some facilities may differ a little bit on that. All right. Here's a nice picture of that blood tubing. So it's Y tubing. One side goes up to the saline, the other side goes up to the blood. You'll see that filter in the middle, and then the line that goes to the client. So the way this is set up is first you keep the side with the blood, that tubing stays capped. You close both roller clamps on the top. That's really important. And this line gets primed with normal saline, because we wouldn't want to start blood. We can never start fluids through a dry line. So we would prime with normal saline. Then once we have our blood, we would shut the roller clamp to our saline and prime the rest of our tubing, starting the infusion and letting that blood flow. One thing that's important with blood, I'm going to go back to this slide, is that, oh, it won't let me go back. One thing that's important with blood is that every blood bag has a different amount of milliliters of blood in it, which is really interesting to think about. And that's just because when it's collected from the person donating the blood, everybody gives a different amount of milliliters on a certain day based on their wage and their age and all those different types of things. So it's not like, oh, there's exactly 300 milliliters in this bag. It's going to vary. Okay. Blood transfusion complications. So if you would suspect that within that first 15 minutes or anytime your patient's receiving blood, that they're having some sort of reaction to the blood, we would stop the infusion, stop the pump from pumping, okay? We wouldn't want any more of that blood to go into the patient. So that does not mean we start the saline and we flush all that through, because as that saline would be flushing through, we'd be giving that patient the rest of the blood that was in the tubing, and we don't want them to have anything else from that blood. So we would stop the pump completely, okay? Things we're looking for are fever, urticaria or hives. Other signs of a hemolytic reaction or a blood transfusion reaction are back pain, chest pain, chills, fever, shortness of breath, nausea, vomiting, feeling of impending doom. So if your patient ever tells you, like, I think something bad's going to happen, listen to them, okay? Anaphylactic reaction, which you've learned about, or circulatory overload. So there's too much fluid on board. Usually these hemolytic reactions occur within minutes. So that's why we stay with our patient for that first 15 minutes. And we don't spend that 15 minutes distracted, okay? We can, chart a little bit if we're looking at our patient, but we aren't, we're in there to monitor our patients. We're not in there just to hang out and look at our computer screen. So make sure that you're monitoring your patient, asking them questions. How do you feel? Assessing their skin, those types of things. What's happening during these reactions is the incompatible blood causes a destruction of the red blood cells. And when that's happening, that's what causes these things to happen. Your patient may not get all of these things. They may just get one thing. They may just have a fever, or they may just have back pain, or they may just start vomiting. So you need to be aware that all of these things fall under those complications. So, little review question. A nurse is assessing a patient and finds small red, purple dots over most of his skin surfaces. The patient denies noticing them before. Which action should the nurse take first? Okay, report the findings immediately to the RN or HCP, healthcare professional, document the findings objectively in the medical record, assist the patient to apply lotion, administer an antihistamine as needed. Okay, so these small red purple dots, those are petechiae, right? So hopefully this question helps you think about, you aren't just studying the term. You aren't just studying in this course or any of your courses coming forward. You aren't just studying what's petechiae. You're studying what's petechiae and what would I do if I found it? How would I respond to it? Those types of things. So you have to push yourself to think one step further in everything. So the correct answer is A, report the findings immediately to the RN or healthcare provider. All right. So, think about that when you're studying. Don't think just about what are the signs and symptoms of a blood transfusion. Think, what are the signs and symptoms? And if that happened, what would I do? Okay, what are the signs and symptoms of anemia? And if my patient had anemia, what might I do? What might they get? What might my interventions be? So if that helps you kind of think about it, hopefully just to push yourself a little bit past just that simple memorization, that won't be enough to help you dig deep into med-surg type content. All right. Questions, please let me know. And thank you so much for listening.